So historically, the mast cells have existed for millions of years. Species like, octopi and mollusks and lizards have mast cells, and clearly they don't get allergic reactions for which we know the mast cells to be involved in. The actual information about mast cells date back to the beginning of the 1900s. So an experiment had been done out of the Principality of Monaco, where they ground up tentacles of jellyfish and they injected them into dogs. And the scientists thought that the dogs were going to be protected from subsequent stings, and they were ready to call the phenomenon prophylaxis. Instead, the dogs dropped their blood pressure, the bronchi constricted, and they died, so they called it anaphylaxis. And at about the same time, in 1887, Paul Lurley was staining various tissues and used a dye called toluidine blue, and he was surprised to see that some cells shown in the middle panels were turning little violet. And he could see dots inside the cells, and he thought the cells were feeding surrounding tissue. So he used the Greek word for breast, mastos, so he called them mast cells, but they don't feed any other cells, but the name somehow survived. If you look at the box at the right-hand side, they do come from bone marrow precursors, go through the blood, and then out into the tissues. So they're never mature in the blood as compared to basophils, which are somewhat similar. They do express unique receptors on their surface, especially the receptor for immunoglobulin E and a receptor for the stem cell factor called c-KIT or CD117, but cancer cells and melanocytes have that receptor as well. If you look at the right-hand side, the red arrows point those violet cells. They're all perivascular or almost perivascular. And we never understood how the mast cells could bind immunoglobulin E because it is circulating. But if you see at the left-hand side, the arrowheads indicate that the green-yellow mast cells in the bifurcation of a blood vessel throw filopodia through endothelial cells, and they sense what's happening in the lumen. Therefore, the mast cells, by virtue of the fact that they're found in eyes, nose, lungs, skin, gut, they sense what's happening on the outside, but they also sense what is happening inside the lumen. The mast cells are also found in the brain, although we don't quite understand what they do. I wrote a review back in 1990 calling the mast cells the immune gate to the brain, because if you see a caricature in the middle panel, you see the blue are the violet are the endothelial cells, the blue are the pericytes, and the mast cell is sitting on the top. And at the right of that, you see an inductor micrograph about 30,000 magnification from my lab up in Boston, where you see an erythrocyte inside the lumen of a blood vessel from the hypothalamus. Then you see the E is the endothelial cell, P is the pericyte, and you see at about 11 o'clock a mast cell hugging the blood-brain barrier. And with many publications, we and others have shown that the stress hormone, corticotropin releasing hormone, can increase the permeability of the blood-brain barrier by stimulating the mast cells. Mast cells are also found in the meninges and in meningiomas, and quite importantly, they're found in the hypothalamus and amygdala that regulate homeostasis and emotions, which might be important for the diseases other than clear-cut allergies. This is pretty much a mini course on mast cells. The mast cell has numerous receptors, as you will see in another slide. I chose to show the most important receptors, and clearly the location of the receptors on the surface is irrelevant because they're all over the surface, obviously. And we wrote about the mast cell and related disorders in a review in the New England Journal of Medicine back in 2015, as you can see at the left-hand side. So the typical receptor that is recognized for mast cells is the receptor for immunoglobulin E. So if the body has been exposed to an antigen, B cells become plasma cells. They make IgE antibodies. The antibodies uniquely bind on the surface of the mast cells and the basophils, and they wait there for the antigen to come back and breeds those receptors, and then that throws the mast cell into a cascade of reactions, starting with increase in intracellular calcium ions. that leads within minutes to what we call degranulation or exocytosis. And the box at the left-hand side shows those molecules that are released very fast. So, of course, we know about histamine, we know about leukotrienes, platelet activating factor, the enzymes chymase and tryptase, but also the mast cells are the only immune cells that have pre-stored tumor necrosis factor. And when that happens, the mast cell looks like what you see at the left-hand side. The brown is the nucleus, the dense blue granules are intact, and the sort of swollen violet granules are the ones that have released their content. And you can see it originally, and then eventually those lagoons will be empty. Now, about 7 years ago or so, another receptor was identified. You can see it at about 9 o'clock, MRGPRX2, which is activated by cationic, positively charged molecules. It can be drugs, it can be substances in the body, it can be hormones, whatever. It's a low affinity receptor, unlike another receptor that I will mention, meaning that it requires a lot of material to be triggered. But importantly, if you look at the publication attached to it, it shows that this receptor somehow talks to the receptor for IgE. And in fact, we've seen that, and I'm sure you have seen that, where individuals may be allergic to something, then they're exposed to something else, now they're allergic to many more things. So it seems like activation of one receptor feeds into activation of the other receptor. Now, if we look at the right-hand side, that's much more exciting to me because if you look at about 12 o'clock or so, there are high-affinity receptors for molecules such as substance P, neurotensin, CGRP that is involved in migraines, etc. Then you see at about 2 o'clock receptors for molecules released from immune cells, such as interleukin-1 beta, interleukin-33. At about 3 o'clock, you see receptors, toll-like receptors, TLRs, activated by bacteria, fungi, and viruses. And what is amazing is that when this happens, the mast cells do not degranulate. So forget what is happening at the left-hand side. Instead, over a period of about 6 hours, they start releasing pro-inflammatory molecules. The first dot is cytokines, the second dot is chemokines, the third dot is peptides that are pro-inflammatory. And if you look at the caricature in the middle left, which is taken from the New England Journal of Medicine article, you can see numerous drugs, peptides, cytokines, environmental triggers that lead to activation of the mast cells to release pro-inflammatory molecules without histamine, without tryptase. So by measuring just histamine and tryptase, I think we're just missing the forest for the trees. We showed, and this is sort of more background, but just to make the point, that if we use a peptide substance P together with a cytokine L33, the mast cells are stimulated to release amazing amounts of tumor necrosis factor as well as interleukin-1 beta, more so than I've seen from many other immune cells. And we had published before that interleukin-1 stimulates the mast cells to release interleukin-6 without histamine or tryptase. And at the right-hand side at the bottom, I show one publication of many that interleukin-6 reflects actually severity in mastocytosis patients, especially associated with bone pain and what have you. So even though interleukin-6 obviously doesn't come only from mast cells, in the absence of any other inflammatory disease that might be related to IL-6, measuring IL-6 could be quite important. The mast cells don't live in isolation. They can talk to macrophages, M, they can talk to T cells, and as I said, they can be stimulated by bacteria and other pathogens through TLR receptors. So I chose two papers at the right-hand side to show you where Borrelia, which is involved, as you know, in Lyme, can stimulate mast cells to release only cytokine release. Sporothrix, which is a kind of fungus, can stimulate release of IL-6 and TNF, no degranulation. And we showed just about a year ago that recombinant coronavirus spike protein can stimulate human cultured mast cells to release interleukin-1 beta. And when we pre-treated the mast cells with antibodies against various receptors, it was the TLR4 that is involved. So when we block TLR4, we reduce release from IL-1 beta. So clearly the mast cells are involved in many processes, and it would be silly for us to just limit ourselves only to the release of histamine or tryptase. So now a little overview, more practical overview. Uh, we separate mast cell disorders in three categories: primary, which is mastocytosis, and it could be systemic or cutaneous mastocytosis; secondary, which is pretty much what we see all the time: allergies, urticarias, and sometimes accumulation around solid tumors like breast cancer. And then we have the idiopathic, which means we don't really understand what is going on. But in addition to idiopathic anaphylaxis, which can be very serious, now we have the issue of mast cell activation syndrome. Everybody now is talking about MCAS, but there's also mast cell activation unspecified, and I will clarify that in a second. Unfortunately, you see at the right-hand side, there are many confusing definitions. So we talk about mast cell disorders, allergic diseases, atopic disorders, where the mast cells are primarily activated through IgE; mast cell disease or disorders, mast cell activation disorders, mast cell activation associated disorders. So everybody's using a term that they think might be the best, and it's confusing everybody. The important thing is, if you look at the bottom right, sort of orange table, there are diagnostic codes that can help us actually navigate through all of this. So for idiopathic urticaria, there's a different code. Atopic dermatitis, a different code. But most importantly, mast cell activation unspecified has its own code. Mast cell activation syndrome has its own code. And then there are other mast cell activation disorders with a different code. So I don't understand why our colleagues are stuck just to MCIS, and patients are going crazy because MCIS, by definition, by those who define those definitions, must have elevated tryptase, about which I will talk about, while in other mast cell activation disorders and mast cell activation unspecified, tryptase is not elevated. So we can still the patients, yes, you have a problem, here's the code, and you don't necessarily have to have high tryptase. Now, what are the conditions that we mostly deal with? So we have the atopic disorders where IgE is primarily involved, and you can see them. But one important one that I've mentioned over time in the group is alpha-gal allergy. Alpha-gal is found in red meat, and I'll show you a slide maybe later if I have time, but it's primarily through pork and beef, or through tick bites, and the ticks might have bitten, a cow or a deer or a squirrel, etc. Then you have the non-atopic disorders, where you have angioedema, hereditary hypertryptasemia, I'll tell you about this shortly, non-IgE food allergies, perennial rhinitis, which is not allergic rhinitis, etc. And if you care to watch, many years ago, I put together a YouTube on the spot while I was seeing some patients in Denmark, and two patients, one from Denmark, one from the US, present their symptoms, and I go through some slides, some definitions. However, before we actually go on with the mast cell, we have to keep in mind that histamine doesn't only come from mast cells. Histamine is plentiful in various foods, shown in the middle panel, such as avocado, cheese, nectarines, sardines, peanuts, etc. And if histamine is released, whether it's released from mast cells or from foods, it can stimulate, as you can see in the caricature at the bottom left, taken from an editorial of the New England Journal of Medicine. It can sensitize sensory nerve endings in the gut and the stomach, and it can cause pain. So what might call colicky pain in children could be, in a sense, intolerance to histamine. And this editorial was based on an excellent paper published in Nature, which you see at the upper left-hand side. Local immune response to food allergens drives meal-induced abdominal pain. It's important to keep in mind that some enzymes are important to measure, if possible, if we're going to do sort of more personalized medicine. So diamine oxidase is the main enzyme that breaks down histamine. It can be measured, or we can measure the gene and see if there are any polymorphisms. COMT is important also because it destroys phenols, and catecholamines are phenols, but some of the products we will talk about later are phenolic. And the CYP enzymes are the ones really that are involved in breaking down pretty much everything. So if we're going to give 2 or 3 different drugs to patients, I'm clearly a proponent of knowing what we're dealing with, because we can separate the patients in slow metabolizers and fast metabolizers, and we're going to adjust the treatment that way. Going back to the New England Journal of Medicine, 2 points to make. One on the caricature at the left, that depending on what triggers the mast cells may release different molecules, and those might affect every organ or tissue in the body. So don't be surprised, and I'm sure you're not surprised, when we see patients coming in with 20 different symptoms, and many colleagues think they're crazy and they kick them out the door because it couldn't possibly be that they have so many symptoms. To make things worse, if you look at the table at the right-hand side, there are many conditions that mimic mast cell disorders. And by mimic, I mean mast cells may be involved, but not necessarily the beginning and the end of the pathogenesis. So I added asterisks for those conditions where we are pretty sure the mast cells are involved. But there are other conditions that might be very confusing. For instance, carcinoid syndrome involves enterochromaffin cells that release serotonin rather than histamine. But the clinical symptoms are dropping blood pressure, flushing, and headaches, which are very typical of mastocytosis or mast cell-related disorders. So you can see how they can be very confusing. From the New England Journal of Medicine, we had created an algorithm for mastocytosis patients. And I know many of us will not be dealing with systemic mastocytosis because it might go towards hematologists. But there are a few points I want to make. If you look at the rectangle sort of at the top, if there's a history of reactions to foods, medications, contrast media, insect stings, that is a telltale sign that mast cells are being activated. So then you basically measure in the blood serum tryptase. And as you will see, in 2015, it used to be 11.5. Now it's actually higher than that as a cutoff. I have a slide for that. And then what you can do flow cytometry for these receptors showing kind of a little farther down in the panel, CD117, 25D2. If those are present on the precursor mast cell circulating, then we have to think that there might be at least mastocytosis, because those are not increased in mast cell activation disorders. And if those are increased, then you send someone for bone marrow biopsy. And if you look at the bottom, stained especially for tryptase, if you look at the right-hand side, we're looking there islands of like 100 mast cells. We're not talking 1 and 2, which are always found in biopsies. And it should be bone marrow biopsy, because if they do a bone marrow aspirate, the shearing forces of pulling to get the aspirate will degranulate the mast cells and you will not be able to see them. If all of those are absent and you still have a lot of symptoms to deal with, then you look for 24-hour urine or first morning void for the metabolites of histamine, methylhistamine, or MIA, methylimidazole acetic acid, prostaglandin T2, or the breakdown product, which is prostaglandin F2 alpha, or leukotriene C4. As you can see in another slide, these are much more indicative of mast cell activation than tryptase. And that will lead you to consider mast cell activation syndrome. If someone has lesions, as you can see on the right-hand side, and this is an extreme because you can see individual lesions which are called just single mastocytomas or solitary mastocytomas, then clearly this looks like cutaneous mastocytosis, unless it's a viral infection of some sort that you can rule out. Interestingly enough, unlike urticaria, which itches all the time, these lesions itch only when you scratch them. It's called derriere sign. And children are the most likely to have cutaneous mastocytosis. I've seen numerous children born with cutaneous mastocytosis, God knows for whatever reason. In about 90% of the time, by adolescence, this disappear on their own. And unlike the bone marrow mast cells that depend on stem cell factor to activate c-KIT, in biopsies of cutaneous mastocytosis, that doesn't seem to be involved. So it's got to be some other factor that triggers the mast cells. We suspect nerve growth factor, potentially other factors as well. Now, at about 10 years ago, friends and colleagues of mine, Jem Akin and Peter Valent and Dean Metcalf from NIH, came up with this new syndrome, mast cell activation syndrome. And if you look at the blue box, I know it's a very busy slide, but you'll see why in a second. In the blue box, you have to have symptoms consistent with mast cell activation. We went through those. You can give some antihistamines or steroids or Chromaline and you get a little benefit. And eventually you measure mast cell mediators either in the blood, in the urine, you find them elevated. So far, so good. What was important in my mind back then, if you look at the upper left-hand side, for the first time, they said accompanied by neurologic complaints. It was the first time the mast cell activation had been associated with neurologic complaints. For reasons I don't understand, the same colleagues dropped the neurologic complaints from part of the symptoms of the presentation. However, if you look at the middle left-hand panel, Dr. Basophil, shown in the middle there, with Dr. Walker from the Mayo Clinic, unfortunately, they're both retired, or fortunately for them, they showed very convincingly that whatever they measured in the urine in terms of metabolites can pick up mast cell activation in about 90% of the cases, while elevated tryptase was picking up only about 20% of the cases. So clearly measuring those, which are unfortunately not measured by many of the clinical labs, is very important. But since that time, and since recognition of mast cell activation disorders became available, now we're seeing association of mast cell activation with what is called the triad, Ehlers-Danlos syndrome, and POTS, post-cell tachycardia syndrome. And you can see a few papers. They're not the best papers in terms of the fact that they're based on anecdotal information most of the time, but more and more we see dysautonomia, hypermobility, and mast cell activation. I don't know why this is the case. With some colleagues, we actually went through an IBM database and looked at about 10 million people. We're about to publish this, and there's no question that mast cell activation, by whatever definition we use, is 7 to 20 times, depending on the papers, more likely to be present together with POTS and EDS. So we should be aware of those. Now, about 5 years ago, a colleague, Dr. Lyons at NIH, for the first time reported what is familiar hypertryptasemia. If you look at the right-hand side lower panel, just to remind you, if you look at the top circle, you see 4 Bs. Tryptase is stored inside muscle granules as a beta tetramer, and it's bound to carbohydrates such as chondroitin and heparin, and it's inactive. Once it's released through degranulation, it separates from the proteoglycans and it becomes active. What Dr. Lyons identified was A, if you look at the lower sort of oval shape, A monomers or dimers. So those can be picked up by the assay when we ask for tryptase measurements, but they're inactive. And yet, if you look at the left-hand side, those who have hypertryptasemia, look at the numbers. 70% have, GERD. Then they might have pain and arthralgias. About 55% have flushing. 50% irritable bowel syndrome. So questions that I've been asking that are still unanswered is, how is this protryptase, because it's not the full tryptase is released, since it's not inside the granules, can its release be inhibited? And since protryptase is inactive, how does it lead to all of these symptoms? And no one really knows to this date. Now, every year, colleagues come together and they create sort of new ways to define mast cell activation. And in all honesty, I hate it because every time they introduce something that throws everybody off. And you can see here a whole bunch of people on the upper left-hand side, and all of those are well-known colleagues of mine, and you will notice I'm not there. And I'm not there because I always take everybody to task that this kind of classification doesn't help us. And if you look at the paper underneath, you see that recently they gave up the 11 nanograms per ml, and they called it 15 nanograms per ml of tryptase as being pathognomonic. But most importantly is the paper on the right-hand side and the one editorial at the top, my friend Mariana Castells. So she wrote the editorial based on this paper shown in the middle right. And what they did, they looked basically at hundreds of patients and they measured tryptase in their blood. And what do you know? 90% of the people that had high tryptase were either familial hypertryptasemia or, which surprised the hell out of me, chronic kidney disease and some neoplasms. So 70% of those who had high tryptase had chronic kidney disease, and another 20% or so had familial hypertryptasemia, and only 10% were actually mast cell related. I mean, that's really amazing. So we should keep that in mind, that high tryptase, bordering at about 50 nanograms per ml, might be indicative of other problems that we should be aware of and not necessarily think only of mast cell disease. So a little more practical now. How do I identify it? If you scratch someone's back or someone's arm, and you can see at the lower left-hand side, and in about 2 minutes, you create this reddish kind of welt, that's called dermatographia. And that means that the mast cells in the skin responded just to the pressure of your finger or a pen that you use to scratch the back or the underarm. That alone is telling me we're going to have problems somewhere with mast cells. And if you look at adults or children, unless they haven't slept for 3 days, and they have black circles under their eyes, we call them those allergic shiners. That's indication that, again, the mast cells are hyper, and we're kind of waiting to find out why. So what test are we doing, or what test maybe should we be doing? So obviously we measure IgE, but IgE by itself doesn't say that someone will be actually allergic, but it's most likely that he or she might be. I always like to measure subgroups of IgG 1 and 4, because the G1 tends to be the good guy, G4 tends to be the bad guy, and IgG4 is definitively associated with food intolerance, if not true food allergy. And 2 papers have also shown that IgG4 is high in children with autism. Now, it may be high in other kind of neurologic conditions. Then I like to do an allergy profile, meaning immune IgE. We used to call it the RAST, R-A-S-T test. I cover alpha-gal, which is galactose, alpha-1,3 galactose. I cover the basics: casein, egg, gluten, mixed ducks, dust mites, mixed grass, mixed molds. These are the ones that are likely to come up. If they come up, then you can actually do much more definitive searching for different types of molds, grass, etc. I also, if I suspect that people respond to foods, I do like to order a food intolerance panel that measures IgG4. However, if you eat something every day, it turns out to be false positive. So I usually request that someone, if possible, eats like boiled chicken and quinoa that has no gluten for 3 to 5 days, and then do the blood draw. There are many different companies that do the testing. One that I like is Pinner Test in New York. They can send you a kit. You drop a drop of blood in there, you send it, and they send you back results for about 250 foods. Clearly, we measure tryptase with the provisos that I just described. If there's a lot of diarrhea, I might suspect carcinoid syndrome, and then you measure chromogranin A, but you have to be off all antacids for about 5 days, otherwise you get a false positive. And unfortunately, many of my colleagues tend to suggest that chromogranin A is released with histamine. It's absolutely not true. I also like to measure eosinophilic cationic protein or eosinophilic protein X, depending on the laboratory. They're both released from eosinophils. Eosinophils many times go together with activated mast cells, but both of these proteins are toxins that activate mast cells. So you might have eosinophil collection because you were bitten by a tick, for instance, and we see collection of eosinophils and basophils underneath the tick bite, and they might be the ones triggering the mast cells. If we suspect that there is an inflammatory chronic problem like long COVID, for instance, etc., then we can measure some cytokines and chemokines. I measure TGF-beta, even though that's not necessarily associated only with mast cells, but I've seen a number of people with off the ceiling, basically off the roof, like 30,000 units of TGF-beta, and that just triggers me to look somewhere else. Something else is happening. We used to think that TGF-beta is a good guy, but as it turns out, it's associated with cancers, especially mucosal cancers in the mouth, and it's been associated with leukoplasia as well. TNF-alpha, of course, goes together with the cytokines. If I suspect intractable itching in the absence of anything else, I'll measure parathyroid hormone. And I would also like to measure VEGF, especially if someone has edema. Vitamin D3 tends to be sort of regulatory for the immune system. So I like to measure because if vitamin D3 is very low, then clearly I would like to replenish that. Now, there are a number of molecules shown in green at the bottom that, our lab, your lab, basically is trying to look into and create a better panel because they have been associated with mast cells more so than tryptase. Bradykinin is 10 times more vasodilatory than histamine. It's coming from mast cells. Chymase clearly comes from mast cells, but many labs don't measure it. CRH is a major trigger of mast cells, and it resets the reactivity of the mast cells. Heparin, surprisingly, is plentiful in mast cell granules, even though the mast cells are not involved in, clotting or anti-clotting, if you wish. IL-11, I'm acutely interested in because there's one paper published in Nature recently that it might be probably the best indicator of inflammatory distraction as it might relate to loss of longevity in humans. IL-31 is more itching causing than histamine. IL-33 resets the reactivity of the mast cells. This receptor that I mentioned earlier, which is activated by positively charged molecules, is shed from the mast cells. So in chronic intractable urticaria, many times we see that elevated. And then these peptides, angiotensin, osteopontin, and substance P, that also trigger the mast cells. It would be wonderful. It would create basically a ready-made panel for something like this. Would be the only ones using it. But you might have heard of what is called the Basophil activation test. In about 50% of the people with chronic urticaria, nothing helps. And what we do is, since we cannot isolate the mast cells, even though I'll come to that, we can isolate basophils or just get basically the whole blood that has the basophils and then use the plasma from another patient, add it to the basophils. And if the basophils are activated, that means that there was something in the blood of the patients, and we're looking for antibodies against the IgE receptor or antibodies against these molecules that show up on the surface of the cells. So many times it's very confusing because we don't know how to order it. It can be called basophil activation release assay, basophil autoantibody, anti-IgE receptor, etc., etc. And in many places, it's put together with other things, like in Quest, for instance, you have to go to urticaria panel 2, and then they measure, they call it histamine release, but then they have antibodies, and I don't understand why they have those thyroglobulin antibodies there. And they have also IgE antibody, as you can see. So we almost have to search, where to look for it. But you can see at the bottom, there's more and more interest in mast cell versus basophil activation as an allergy test. And Dr. Kembras and Dr. Bhaskaran, very actively are trying to set up a culture of mast cells in the lab that is convenient and reproducible, so that instead of doing the butt test, we might be able to do actually adding the serum of the plasma directly onto culture mast cells, which will be a much better test that we can use for patients. So in terms of other diagnostic tests, as I already said, measuring breakdown products of mast cell mediators in the urine is important. I'll just mention what I mentioned before, N-methylhistamine or methylamidosalicylic acid. In my mind, the MIA is better if you can find it anywhere because it measures about 60% of the histamine broken down, while NMH at its core measures only about 20%. And that's because the NMH goes on to become oxidized and becomes MIA. And that I mentioned prostaglandin D2, the breakdown product. FHIAA, we measure if we suspect carcinoid syndrome, is the metabolite of serotonin. Metanephrines are the breakdown products of catecholamines. So if someone is, going crazy day in and day out, clearly I want to know why he or she is stressed out. And sometimes it might be that they're just putting out a lot of material. And that if possible, we can do heavy metals. It can be done in blood, but it only lasts about 3 months, urine 6 months, and then of course, hair. If someone is having a lot of gastrointestinal problems without necessarily other systemic problems, then I ask for total histamine. Unfortunately, in the US, they don't measure histamine in the stool. In Europe, they do it. Calprotectin, which is an index of inflammation. And again, the proteins that I mentioned, eosinophilic cationic protein or protein X. Other diagnostic tests, clearly I mentioned diamine oxidase. These are all genetic polymorphisms. And as I said in another meeting, I'd rather we find a company that does just these, because if we do all the polymorphisms, that's about, sometimes $800 worth. And that we need someone to go through them and tell us, what they all mean. Many times they're not associated with any pathogens. So DAO, clearly important. Also MAO can break down histamine and phenols. And at the bottom, not associated with mast cell necessarily, but about 40% of children on the spectrum, about 20% of adults have polymorphisms on the enzyme MTHFR that turns folic acid into its active form. And it's important to know, especially if someone has brain fog. So putting this together very pedantically, and we wrote a review recently, if you put the mast cell in the middle, it can be stimulated by triggers that might be released from damage of any tissue, in this case, skin. Molecules will travel through the blood, will activate the mast cell to release molecules that can activate sensory neurons. Stress will cause the release of CRH that will reset the reactivity of the mast cell. The mast cell release more molecules that activate neurons and microglia, and there you have it, basically. You've got a cycle. And at the right-hand side, a very old paper from my lab up in Boston, 1999, showing the mast cells basically touch neurons, as you can see in a low light micrograph and an electron micrograph, where two portions of mast cells with a granule showing are very close to a nerve ending. So how do we address mast cell activation now? Well, clearly we have to avoid or minimize exposure to. And the exposures many times might not be necessarily what we think might be causing the problem. For instance, we know about house allergens like dust mites, mold, but cleaning supplies can trigger mast cells. Colorings, especially yellow 5 and red 40. Deodorants is a major trigger of mast cell activation disorders. Flame retardants, and it's quite interesting, many of the non-rinking clothes are basically sprayed with formaldehyde, and formaldehyde will stimulate the mast cells. Herbicides such as glyphosate, which I'm sorry to say still available as Roundup everywhere. Monosodium glutamate found in many spicy foods, especially Oriental foods. Polyethylene glycol, that is a major preservative in everything, including COVID vaccines, and preservatives like Twin 80. So then we go to antihistamines, but not all antihistamines are the same. So here's some antihistamines shown on the left-hand side. Bilastine is not available in the States, available in Canada. Rupatadine, shown in the red rectangle, is not available in the States, is available in Canada, and of course in Europe. And then we have to keep in mind that other drugs, such as tricyclic antidepressants and phenothiazines, are also antihistaminic. And the reason I'm saying that, because if we give too much of antihistamine, all antihistamines are also anticholinergic, and they might put someone in retention. So we have to keep in mind that too much of something is not necessarily the best. I'd like to show the papers on the right-hand side for rupatadine, because rupatadine is the only antihistamine made to also block platelet activating factor, or PAF. PAF is well known to be involved in allergies and inflammation. And I was the editor of a whole review a few years ago about PAF. But it is so labile that it cannot be measured in any clinical lab, so we don't pay attention to it. However, if eosinophils are involved, whether it's eosinophilic esophagitis or gastroenteritis, then it's important to keep this drug in mind, because it blocks the ability of PAF to stimulate eosinophils. And you can see at the top two papers from my lab where rupatadine inhibiting mast cell activation through either different triggers in the top paper or the middle paper due to PAF itself. So PAF is released from mast cells and acts back into the mast cells. Here's another paper, not from mast. The ropatidine can block basically activation much better than, in this case, was compared to desloratadine and levocetirizine. And at the bottom, a paper published primarily from my late old friend, Dr. Mauer, an incredible physician scientist from Charité in Berlin, who vacationed in his home in Italy, and he was found dead basically 5 days after he disappeared. That happened a few months ago. So many antihistamines may have different effects. To give you another effect, in the middle of the panel, the left hydroxyzine, we tend to give it at night. It's sedating, but it's also anti-anxiety. So we might choose basically different antihistamines. Cyproheptadine, shown a little higher up, it's both an anti-serotonin and a mast cell blocker, so we commonly use it in carcinoid syndrome. Now, one thing that pains me, among other things, is Dow supplements. So there are supplements that give diamine oxidase in order to break down histamine, whether it comes from food sources or released from histamine in the intestine. The first thing that we should be keeping in mind is that this is an enzyme. So unless it is in an enteric-coated form, the pH in the stomach will destroy it. And there's nothing here that is enteric-coated. Maybe one that I'll show you farther down the line. So don't necessarily just give Dow supplements. They're just not going to work. And many patients say they don't work. That's number one. Number two, all of them are actually, except for one, which I will mention, from pig, and many ethnic and religious groups cannot do pork, and therefore they cannot use it. Third problem is you can see the units, 18,000 units, 20,000 units. And then you go down to NaturDAO, the one before the end, that presumably it's from pea sprouts or bean sprouts, and now it says 1 million units per tablet. There's nothing there. Pretty much everybody using NaturDAO says it doesn't help them at all. So I've been talking to 3 different companies, trying to convince them to create one that, as you can see in the middle, HistaGest DAO. It's still for porcine, and it says tablet gastro resistant. So that might actually be doing the job. A company now is trying to make it recombinant in yeast, and the company from Spain is trying to create one in resistant capsules or tablets. I'm kind of getting towards the end. We know that we can use Chromaline in some of these diseases, and I published my first papers as a student at Yale, Chromaline in, God knows, 1974. Chromaline works like a charm in rats, but it's not very good in humans. Why? First of all, look at the paper at the left-hand side by Dr. Church from England. If you look at the red rectangle, it says histamine release was induced. Sodium chromoglide was a weak inhibitor of histamine in PGD2. You had to use pharmacologic concentrations to block it. To make things worse, if you look at the right-hand side in the middle, still from Dr. Church, it's a biphasic curve. You go high up, you do whatever benefit you get, and then it starts stimulating. And what is the stimulation? If you look at the green box, it causes diarrhea and alopecia in about 15 to 10% of the people. Less than 5% is absorbed from the gut. So if it's going to be active, it will be only in the gut. Rapid tachyphylaxis. We start with 100 milligrams a day, and before you know it, you're 400 milligrams 4 times a day, and then it stops working. So it's a tricky drug to use, but if it works, it works. For those people that works. However, Dr. Galli, who is chief of pathology at Stanford, published a paper, among many others, where the mast cell stabilizer, as we used to call it, Chromaline, doesn't even work in mice. And that's the fallacy about using animals. When I published, it was in rats, it worked like a charm. It doesn't work in mice. Maybe it works in humans. So what do we do then? So since almost 20 years ago, I've been studying, as you all know, flavonoids. This was a paper we published in Pharmacological Reviews back then with Dr. Middleton, who was the father of flavonoids. And you may know, I might have told you that, but he died many years ago. And I got a phone call from his colleague and then from his wife that they wanted me to pull all the work that he had pulled together over the years. in a review, and we wrote that review. Here's the structure of luteolin. It has 4 hydroxy groups, therefore it's phenolic. Many reviews have been written. You see one in the middle, antioxidant, anti-inflammatory, anti-allergic. You see one on the right, fairly recent, luteolin is potentially immune system modulator. So we bit the bullet actually about a year ago, and we published this paper that you see at the bottom left, where we compared equimolar concentrations of luteolin and chromalin to see whether it would inhibit various mediators from human cultured mast cells. And you see the slide to the right. So the first bar is control, the second bar is stimulation with whatever trigger we used, the third bar is inhibition by luteolin, the fourth bar is inhibition by chromalin. And as you can see, luteolin was really much, much better than chromalin vis-a-vis every mediator we measured. And we showed that by comparing chromalin luteolin and another molecule called methoxyluteolin. And as you can see now, there are no hydroxy groups. So this molecule is already methylated, so it's not broken down in the liver, and it serves as methyl donor actually for many individuals that have methylation defects, especially children with autism. And a recent paper, well, sort of recent paper, showed that lemon seed flavonoids can be used as anti-fatigue, and the luteolin that at least I've been using comes actually from lemon seeds. And one of a number of recent papers showing the luteolin can inhibit actually whatever the spike protein can be doing to humans through many other ways that we had covered some other time. So as you know, I had helped make a company in Sarasota, Florida, that makes some dietary supplements. There are 3 points I want to make with this slide. I'm not trying to necessarily promote the company, but there are 3 very important points. One is that luteolin and such flavonoids are absorbed less than 5% from the gut. So we mix them up with olive oil or olive pomace oil, and we can increase absorption 3 to 5 times. And as you can see, olive oil itself has anti-inflammatory properties. That's issue number 1. And I am always a proponent of starting with something that's entirely pure and then building on either to higher amounts or different other products. So pure lute, for instance, is only luteolin in 100 milligrams in a sort of a liposomal form with olive oil. Now, there are other supplements that might be additionally helpful. So you see at the top, for instance, now tetrahydroxyflavone can inhibit mediating allergic inflammation. And we're trying to there will be a new formulation coming out around Christmas or thereabouts from the company that makes those other products, Algonaut. They will have 3 ingredients. One will be tetramethoxyflavone, which is much more potent than luteolin. It will have a natural molecule that has antihistaminic activity, and it will have the enzyme diamine oxidase in a stomach-resistant, actually, a double capsule. So stay tuned. You can see luteolin actually can help with vascular problems as well. But very important in my mind is the 2 middle panels, berberine. I'm sure you know berberine, the hundreds of papers written. Berberine is good for diabetes, metabolic syndrome, but it has anti-inflammatory, antiviral, and most importantly, anti-mold effects. So I recommend it for people exposed to mold all the time. But here are 2 papers that berberine also inhibits mast cells. So if patients cannot tolerate flavonoids because they're phenol intolerant, or we need to add something more, berberine might be helpful. And so could be butyrate. You can see a very recent paper that butyrate increases heparin synthesis and storage in human mast cells. That means the mast cells are more mature and less likely to fire. So I only have one more slide, I think. So if we were to go through a rubric, how do we think about it? So we start with 2nd-generation antihistamines, but because they're not sedating, but sometimes we might want to use, let's say, hydroxyzine, which is sedating for other reasons. Clearly, we can go 4 times up the original amount. So up dosing up to 4-fold if patients can tolerate it. And at some point in here, we're going to add actually a histamine 2 blocker, such as famotidine or Pepcid, not only because chronic disease can do a damage basically through stress and other things to your gut and your stomach, but because two recent papers, I didn't have time to include them now, show that the mast cells have histamine 2 receptors on their surface. And when the histamine 2 receptor is activated, it stimulates further release from the mast cells. So giving a histamine 2 blocker might help with the stomach and might help minimize activation of mast cells. If you have skin problems, of course, you can use cortisone creams, etc., or you can use something called Gentle Derm that the company Algonaut made that contains this methoxyluteolin, which is more potent than luteolin. And just to remind you, if you don't have hydroxy groups, you don't have any color. So methoxyluteolin in this Gentle Derm has no color. Of course, if we suspect food intolerance, as you can see at the right-hand side, we can use diamine oxidase. If there are cognitive symptoms, then we have to consider folinic acid, which is not mentioned here, which is much more active than folic acid. And we might have to use molecules that get into the brain, and luteolin does get into the brain. If there are lung problems, difficulty breathing, then we'll consider an anti-leukotriene, such as montelukast. If there are mostly gastrointestinal problems, then, as I said already, we consider Chromaline. And then we get into more difficult situations where patients don't respond to any of these, in which case we might use omalizumab that neutralizes IgE, but it's injectable, or dupilumab that targets IL-4 and IL-13. But technically, these are given for chronic asthma or chronic urticaria, and therefore you have to justify why we're giving those. For systemic mastocytosis, of course, we can give other drugs, but usually we don't deal with those drugs, such as imatinib, cephalosporin, and now this last drug, avapritinib, that target tyrosine kinases. And this last drug had a recent publication that not only inhibits proliferation of mast cells, actually it causes apoptosis, to be more correct, of mast cells, but it might inhibit activation of mast cells as well. Are there other drugs? Sure, there are other drugs, but we don't really use them as much. And I know Dr. Klimas and some of you have discussed some of those. One of the most promising ones is the one shown on the right-hand side, the JAK1, JAK2 inhibitor that inhibits, in this paper, very recent paper, released from human basophils and mast cells. So far, these inhibitors are not given for mast cell activation disorders, but we might be able to use them since we really don't have anything else. So I'll finish by just showing you this. So we know about mast cell in a number of diseases, such as allergies, anaphylaxis, asthma, eczema. We cover those. But I don't have time, obviously, to cover so many other diseases that you know of where the mast cells clearly play a role. So those are kind of the white or empty petals kind of going around these days. And I had written about this in this review, mast cell activation beyond histamine and tryptase. And one indicative paper was that the mast cells might be involved in neuroinflammation and fibromyalgia. And I know all of us are very aware of these associations. Unfortunately, many of our colleagues are not. But clearly, the most important approach is to start with something that we understand, that we can deal with, and then move on to those other associations. Because what happens many times, patients will come in describing the symptoms related to all the white petals or empty petals, and then everybody gets confused. So we can focus on the ones we can understand, we might be able to expand and cover the other conditions and hopefully help our patients. Thank you very much.